Pain is defined as an unpleasant sensory or emotional experience, usually associated with actual or potential tissue damage. McCaffery further defines pain as whatever the patient says it is. Pain is referred to as the fifth vital sign to ensure that every time temperature, pulse, respiration, blood pressure are taken, pain is also assessed. This ensures that the nurse assesses for pain on a regular basis. Each patient perceives pain differently. My perception of a pain level of 3 might easily equate to another person's subjective pain level of 10. When treating pain, the nurse should consider both pharmacological and non-pharmacological relief measures. Please refer to your Wilkinson text for those recommended pharmacological and non-pharmacological pain relief measures. Joint Commission for the Accreditation of Healthcare Organizations has guidelines which recommend that every patient be assessed for pain and nutrition upon admission. In this pain assessment, the nurse is usually asked to categorize the pain, to ask about those factors that both cause pain and those factors that both alleviate the pain. One of the ways to categorize pain is to define it as either acute or chronic. This has to do with onset. Acute pain usually has a rapid and recent onset, and it is short-lived. Chronic pain, on the other hand, may last more than 6 months, or it is intermittent in nature, which means that it comes and goes over a period of time. Over time, a person adapts to chronic pain and may not exhibit those objective signs that nurses have come to rely on to assess for pain. In acute pain, a person will have elevated blood pressure, pulse, and respiratory rates. Chronic pain, none of these may occur. The pain may be equally as severe. Another categorization of pain is described in terms of how it is translated or transferred to our consciousness. Nociceptors are those bundles of nerve tissue that take the sensation of pain and convert it to an action potential and actually transmit it to our consciousness in our parietal lobe. We have other types of receptors. For instance, baroreceptors are again that nervous tissue that senses a change in position and changes our blood pressure. We have thermoreceptors which sense a change in the body's temperature and again seeks to regulate that temperature. Nociceptors again are those that are more specifically in tune with pain, or that noxious stimuli, unpleasant, emotional, or sensory experience that may be associated with actual or potential tissue damage. Neuropathy or neuropathic pain is really more of that pain that's relayed from the central or peripheral nervous systems. Neuropathy or nerve pain is usually more difficult to treat and is usually more severe in the level of pain. Referred pain is used to describe that pain which is perceived at a site different from the actual tissue damage. Usually patients who are having a myocardial infarction or a heart attack may describe their pain as pressure or tightness originating at the chest, but they sense it in the pain in their neck or in their left or right arm. one theory states that it is possible that this pain is sensed elsewhere because that organ may have no active nociceptors. Remember, heart attack, the tissue's dying. So it may be that the area where the pain receptors are may already have necrosed. Phantom pain is a phenomenon where a person has undergone an amputation of a limb, and yet they still report feeling pain in that limb. Research has shown that this is a real pain, and that nurses should believe the patient's report of pain and treat the pain readily. I'd like to go over two other concepts of pain which we've talked about in class: threshold and tolerance. Threshold has to do with the point that the person actually feels pain. So, if I walk on hot coals and I've walked about 2 minutes on the coals before I actually sense pain, then I would say that I have a high threshold for pain, that I was exposed to probable tissue damage for a period of time before I actually sensed pain. A low threshold would be that as soon as I put my foot over the radiation of the heat from that hot coal, I said, ouch. That person, again, would have a low threshold, so that they would sense pain immediately. Tolerance, on the other hand, differs from threshold in that the person senses the pain, but they choose to endure it. So, I have a headache. I know that I have reached a threshold because I do sense that there is pain in my head. But I'm going to categorize that as a 3, and I may tell the nurse I don't want any kind of relief measures taken until it's a 7. So I sense the pain, not like threshold, I sense the pain, but I'm going to tolerate it until it gets too strong. That would be high tolerance. Low tolerance, as soon as I sense that I have a headache, I want some medication. That would be a low tolerance. And now, I'd like to talk about how pain is actually transmitted. And here we're going to mostly talk about nociceptive pain. There are 4 steps: transduction, transmission, perception, modulation. I like the way this slide says that transduction occurs from the site of stimulation. So this is where the tissue damage occurs, and it's the stimulation of those peripheral receptors. Those peripheral receptors would be the nociceptors. Transmission goes from the nociceptors up through the spinal cord into the thalamus. Perception, this sensation continues from the thalamus to the parietal lobe of the cerebral cortex, and we feel pain, and theorists now say that it is the transmission from the parietal lobes to the limbic region that causes us to respond to pain by crying out loud or by forming tears. So let's go through each one. It starts with transduction. Transduction is the conversion of one energy from another. So we step on something sharp on the periphery. Nociceptors pick up that tissue damage has occurred. The damaged cells release substances that actually activate the nociceptors, and they start an action potential. Action potential being that nervous stimulus that's going to transfer from the sensory side all the way up to our brain. Once the action potential has occurred, it is then transmitted from those nociceptors up to the spinal cord. Once it reaches the spinal cord, it further goes to the brain and into the area of the thalamus, which is like that relay system. The thalamus, again through the release of neurotransmitters, continues this sensation up until the cerebral cortex, and is at that parietal lobe of the cerebral cortex that we reach our threshold and we feel pain. When we feel pain, that is called perception. Once we perceive pain, the body tries to protect us from having an overwhelming response to this pain, and that's the fourth step, which is modulation. Here the body releases neurotransmitters, primarily endorphins, serotonin, norepinephrine, that blunt the severity of the pain. So transduction, where the tissue damage occurs and action potential starts, transmission, the communication of this action potential all the way through to the spinal cord, and finally to the parietal lobe of the brain. In the parietal lobe, we have perception. Body reaches its threshold, person feels pain, and then homeostatic mechanisms try to modulate the pain so that we're not overwhelmed. Patients have different meanings for pain. Some cultures are teach the members to be more stoic for the pain. Remember again, the nurse's primary responsibility is to assess pain as that fifth vital sign, and then to believe the person's report of pain, and then to treat the pain using both pharmacological and non-pharmacological measures. These are some questions that can be asked in the pain assessment. Remember, the basic assessment has to occur by asking the person, are you in pain? If the report is yes, the next thing the nurse wants to do is ask the location of the pain. Can you point to it? Can you tell me where it is? And then we want to ask the severity of the pain. In our class, we're using the numerical scale, so that we're asking them on a scale of 0 to 10, 10 being the worst pain, 0 being no pain. Please rate your pain. There are other scales that would be more appropriate for those patients who are illiterate. We might use the FACES scale, where 10 would be a face with tears, 0 might be smiley face, and 5 might be a neutral face. This is also helpful when we're using assessment skills for children. Children, we might ask them to point to their pain. They may not have the vocabulary to describe the location, but they can definitely tell us where their owie is. So please do not feel that we cannot assess pain in a child by asking them about their pain. Again, other things that we might see on a health assessment for pain: when does it occur, what facilitates the relief, what aggravates the pain, and also what things does what pieces of functionality are impacted by the pain. Can you do your job? Can you perform ADLs? Okay. Again, these are just things you can read on how to assess pain. Remember, with older patients, never believe that pain is a normal part of aging. Transmission and perception of pain are slowed in an older person because the nervous system, those nociceptors, some are minimal, the numbers are decreased. Others, the transmission may be slower, but they still feel pain. They should be assessed on a regular basis, and it should be treated. We should not buy into the myth that pain is a normal part of aging. I hope that this review has been helpful. Again, please refer to Wilkinson for those pharmacological and non-pharmacological measures for pain relief.